All right. Well, thank you all for coming and switching your times. Those of you who could, I this class could actually get better if I was on a bunch of laughing gas and drooling, but I think this is probably the better way to do it so that I'm not in pain and I'm able to talk. So I thank you all very much for adjusting your schedule on short notice. I wanted to start with a quick example of the site specific. It does not have to look like this. It could actually look however you guys want it to look. But this is an example of what somebody did last year. Um, so you can use Excel, you can use a Word document, you can use a Google Doc. I don't care. Whatever you work best in, it could be a PDF, it could even be a PowerPoint, whatever you want. I just want the different sites. I did take out of my grading criteria this year treatment complications, I believe. Um, that is because, what was that tolerance doses? Let me just confirm before I misspeak. I took one of them out of the grading component and I updated it on the PDF on your Moodle. So just make sure that all the criteria I have in the grading component is what you guys have. Um, each individual one, I don't overly grade this assignment. This is just something I want you guys to have for reference in your future, for reference on boards. I'm basically going to say, okay, I have a checklist. Do you have this specific cancer site? Um, do you have this treatment option? Do you have this field border? If it looks good and it's all in there, then I check it and I give full credit for it if it looks like something's missing. But I don't want to have to dig through a 27-page PDF to find the answers to this. I would like it to be very easy for me. I have a lot of these to grade. So you go from site to site. So that's it's kind of how I want it to be positioned. Like I said, Word document, however it is, so it's easy for you guys to understand and for me to understand. Give me one. Okay. So just for the areas, this is due on Sunday. Like I said, this should be very easy for you to read. It's very easy for me to read when it comes time for your board review, when it comes time for you to be doing this in your clinic. Then it would be easy for you to look at this document and see, okay, I'm treating a head and neck. Why is it that they did this? If you don't have maybe a group of therapists around you that are willing to answer this. This should answer a lot of the questions that you would have in your career. So I'd like you guys to have it nice and clean, not only for me, but for you to reference in the future. Does anybody have any questions on the site specific? Okay. I often like these. You guys do a really good job with the organization, with you guys are much more tech savvy than me. And sometimes people put in really interesting photos. They will put in the photos from the book, which is okay. For the field borders, if they have that to reference in the future. So all of that is great. Whatever you think would help you in the future, I want you to put in there. I believe as far as due assignments, that's our next big due assignment this Sunday. In a couple weeks, we have an exam. Probably next week, I will go over the exam. We'll talk about really what we should focus on as far as what I'm looking for in field borders as far as what I'm looking for, in doses as far as what I'm looking for, in what you should be getting out of this class. Again, I know this is a ton of information in this class. It's designed that way because we treated a ton of different body sites. But it should all be understandable. My goal with this class is not to make it difficult and to be hard. It is designed so that you can go back to the clinic and do this job of radiation therapy and do it well and have a really good understanding of it. So that being said, let's finish head and neck. So we will go with our last lecture on head and neck, which would be salivary glands. Salivary glands is a pretty quick lecture. It's only 13 slides in it, so we should be going pretty quickly. Today's class will consist of last lecture of head and neck, salivary glands. We'll get into lung, which is a lot more robust of a topic because there's a lot going on in the lung. We do have a shift sheet assignment that's due, so I want to just talk about for our homework assignment, I wanted to go over a quick shift sheet that's different than the one that's in the homework. And then we have some case studies. So it should be maybe like a 2 hour, 15-minute class. Introduction. The salivary glands is a cell or organ that basically creates secretion saliva for the oral cavity. There are major and minor salivary glands. Major is the parotid, submandible, sublingual. Minor would be the ones in the tongue, the palate, the lips, and the cheeks. So the major salivary gland that we work on is the parotid. Parotid salivary glands are important for us because they create most of the secretion that we use for speaking and chewing. But it is an area that does get treated. It's also an area that if it's not treated and a tumor sits next to it, we try very hard to make sure we get minimal dose to that specific area. These are fun facts. And again, when I have fun facts, sometimes I need to get this information and I don't want to put this information in 5 different slides. So I put it in fun facts, but it's things that I think you should know. The parotid gland is the largest of the salivary gland. Most salivary gland tumors, both benign and malignant, occur in the parotid gland. The parotid is located at the base of the ear. So sometimes we have that sensation when we have something that's very sour and we get that like tightness in the back of our jaw under our ear. That's right around where the salivary gland sits. The primary treatment for parotid tumor is surgery. This is why we don't see a ton of salivary gland treatments on the LINAC, because generally these people are going to go into surgery. When we see them, it's generally because they have regional or lymph node involvement. Why would they get radiation therapy? The primary treatment for certain types of salivary gland tumors would be surgery. So if they are malignant or they are unable to get surgery, then we would take them for radiation therapy. Sometimes after surgery, we would be able to treat them, and this would be if we were in fear of a risk of reoccurrence. Palliative treatment also to alleviate symptoms and improve the quality of life. It's just specific for metastatic salivary gland tumors. And then if they were either radiated previously or they had surgery, and so obviously you can't remove something that's already been removed, then in which case they would come to us for persistent and recurrent tumors. What does the simulation for a salivary gland look like? It looks like a head and neck tumor. So that would be a head holder, a face mask, neck hyperextended. You basically want to lock in this area of the jaw. So you want that mask to be very conformed around the neck area and the chin area. A lot of your head and necks in general, not just parotid, but a lot of them will have surgery. They will have scars. And so we wire those scars. It is something to think about. Every place does this a little bit different. There's no right or wrong way to do it. Sometimes you'll wire the scar and then make the mask. The problem that I've noticed when I do this is when I make that mask, it becomes sticky and moldable, and it'll attach to the wire, and it'll sometimes pull that wire on the patient. For me, if there's time, if you're not in a super busy center, the best way to do it is to talk about what the doctor wants, have the doctor wire the scar or draw where he wants or she wants that wire to go, and then make your mask, let the mask solidify, cool down, and then take that mask off, wire the scar, put the mask back on. That way you don't have that stickage, because sometimes that wire again sticks to the mask, it pulls off, it becomes very uncomfortable for the patient. This is so that that wire sits exactly where the doctor wants it, and your mask, you then know. I love doing this on head and necks anyway, because I feel like when you make a head and neck mask, the patient's like resisting against it and they're not super comfortable. And I believe this is another reason why on the Linac they don't line up perfectly. If I have time in CT and I can give that person the opportunity to relax after the mask for, let's say, 2 minutes, put the mask back on, I know this is how the patient is going to be when the mask is put back on them every day instead of while the mask is being made. So scars wired, and that is because the doctor's going to want to know where the surgery site was. Bite blocks are always a good idea. Just I didn't add or subtract points for that in your guys' homework assignment. I just wanted to know your rationale behind it. As long as you thought about it, there was no right or wrong answer in the bite block. I like bite blocks when they're necessary or when I think they can add benefit to holding a jaw in place. Obviously, with the brain, there's no reason to have a bite block, but anything around the head and neck, if a bite block is available, it doesn't hurt anything. And then a shoulder pull. We definitely want to have those shoulders extended down just to give the doctor a lot more room to work with. Again, all head and necks, this is a big emphasis in this class. Before CT Sim, did they have a dental evaluation? Do they have any decaying or rotting teeth? Did they see Did they see the dentist? Was it within, are they healed from it? Was it after, let's say, 8 days? All those things are great. So once we check all those boxes and we make the mask, then we are ready for treatment. What does it look like? This class is actually easy this week because in our book, there's not a ton of information around how we field border these two specific sites of lung and parotid. But on page 51, parotid tumor, there's a little diagram of it. And it basically just sits on the parotid tumor. And we will go through. Make sure all these people are here. Diego, why don't you tell us on page 52 what a parotid includes in the book? And I'm going to go here.
Are we in portal design?
We are in portal design, yeah.
52?
52. So page 51 is the field. What it looks like on the patient, and 52 is the superior.
And
You
I
could
guess
also read
oh,
the slides.
the superior zygomatic arch, anterior border of the masseter muscles, posterior behind the mastoid process, inferior top of the thyroid cartilage.
Perfect. So this just emphasizes another reason that we want to wire that scar because the doctor wouldn't know how to include all the scar if the scar itself was not included in the CT. Okay, so wiring the scar, making sure that that is nice and visible for the doctor. When I say wire, I'm pretty sure we've all seen it, but it's just those little radio peg movable wires that we cut, we put on top of patients in the scar areas. That's what we mean when we say wire. We don't actually use a wire, a metal wire. It's just a radio peg. It's actually a piece of plastic, but that's what we mean when we say wire the scar. On average, the tumor volume is to include the entirety of the operative bed and 2 centimeter margin. Um, there's multiple ways that a parotid tumor can spread. It can spread through local invasion, just through growing. It can go to the opposite side of the neck through nodal spread. So there's just different ways that these tumors spread, and it's a little bit more complicated. And I'm sure Maureen will go over that in her class. She does the oncology portion of it. But that would be how the doctor is going to plan. If it hasn't spread to the other side of the parotid or too far into the neck, they're going to try very, very hard to salvage the other parotid gland because having one parotid gland makes a big difference versus having no parotid gland. So if you can have half the amount of saliva, you can still eat, you can still talk, you can still function relatively normally. And hopefully you get a little bit, unless you have it removed, a little bit of that salivary function in the affected side. But if it's included into both, then your life drastically changes the more percentage of salivary function that you lose. So a way that we do that is something called a wedge technique. And I currently actually have a wedge on the table. I have a wedge pair. But what this means is you have two beams, let's say it's 3D. So most of us are going to see an IMRT on the table and they're just going to conform the dose away from the area. So basically, this is called weighted. They're going to weight the beam on an IMRT. So basically, the isocenter sits here, and let's say in this area, this area, this area, this area, this area, when the beams are coming in that direction on an IMRT, we're going to weight it. So we're going to give 90% of the dose in these areas and maybe just ever so slightly, like let's say 2% here, 2% here, 2% here. And we're going to give almost zero to this side. It's called weighting the beam. It's basically where you make the beam super heavy onto one side. You give the majority of the dose when it's onto one side. Before IMRT, or let's say this patient didn't qualify for IMRT insurance, you can also do this by what we call wedge pairs. That means we just have two static angles, one coming into this direction, which would be what size is L? Left posterior oblique and a left anterior oblique. Generally, they meet at 90-degree angles. So you have, normally when we treat two static beams, it's parallel opposed, meaning 180 degrees apart. So if you had zero, it would be 180, APPA. Now this, we take from parallel opposed 180 to a wedge pair, which is generally 90 degrees. And that way, when the dose hits at Dmax, it hits right here at the parotid gland, and it doesn't absorb further into the skin. Therefore, the other parotid gland gets negligible dose. In order to also do this, we don't want it to be too heavy right here in this part of the beam. So we add two wedges. Remember, this is the heel of the wedge. The thick part of the wedge is the heel part of the wedge. The thinner part is the toe. So if it's a foot, it's the toe and the heel. These two heels go towards each other. I don't have any questions on this on the exam, on what it means to like how the wedges go in a wedge pair. But I do want you to understand this concept. It's a concept that has been used very frequently over time. Your therapist will probably talk about it. Again, I currently have a sacrum on the table. That sacrum is very lateral. It's a sacral joint area, and I have a wedge pair on the table right now. I don't put wedges in that machine anymore, but I can see my dynamic wedge closing, and I know because that treatment is 90 degrees separated on a 3D plan. So for me, that means it's very weighted one side. And whenever we have a wedge pair on the table, we think, why? Why do I have this wedge pair on the table? Why does this look different than the rest of my treatments? Generally, it's because something's on the other side of that, what we're trying to avoid. The goal of radiation therapy is always to give the maximum amount of radiation to the tumor and to the treatment area while minimizing dose to healthy tissue. So, how do they do this? How do we do it if we only got approved for a 3D plan and insurance didn't approve us for an IMRT? We can do this through what we call a wedge pair, where it's just weighted very off to one side because here I have orbits, I have a brain, I have the other parotid, I have a bunch of other things that I'm trying to salvage right here. So I can do this by weighting the beam with a wedge pair. Another way I can do this is with electrons. So there's a possibility that it's superficial enough and I can hit some of this with a wedge, I'm sorry, with an electron. There's also a possibility that I can maybe do with some photons and electrons and really just pull that dose in, make sure I paint this part of the dose real hot and then this part with some photons and do my best to make sure that the rest of this is getting very minimal dose. So just some options of treatment techniques of how to treat something superficially that is lateral to one side of the body without treating the rest of the body. I moved on to slide 11. So the dose for a parotid, it's post-op, negative margins, no margins. Again, most head and necks get treated pretty heavy. They're pretty high dosed. So 60 to 63 gray, 1.8 to 2 gray of fraction. Remember, if I was talking about this in centigray, it'd be 6,000 to 63,000, and then it'd be 180 a day to 200 a day centigray. If I ask any questions on homework assignments or if I ask any questions on exams and I have a question and it says 1.8 centigray or 1.8 gray, I would expect you to know that if it's 1.8, it would be GY gray, and if it's 180, it would be centigray. Okay, I want you to know those differences. And on your homework assignments, I want you to also be putting the correct unit behind it. I don't really care if you do centigray or gray. I just want it to be the correct number associated. Post-op positive margin, 66 gray and 1.82 gray a day or a fraction. And then if you just have radiation alone, a post-op gross disease, so just no, it's a T1, you have 70 gray, 2 gray a fraction. Again, these are very difficult to treat. We really want to be almost all head and necks are difficult to treat. We want to be very careful in our CT planning, in our ability to reproduce this on the LINAC. We also want to be very careful in our reproducibility and how we're setting these up. If we can do something to make it better and do another CT, we should. We should. If we can move the head a little bit, if the head should be up, if we should move the shoulders, push the shoulders up or down, doing another CT to make sure that these are really good treatments in the linear accelerator, that it's worth it for these because we have a lot of dose limiting structures on head and necks, spinal cords, brain stems, optic chiasms, nerves, the ear, the mandible, the brain, salivary glands, the uninvolved salivary gland. All these make an impact on somebody's quality of life. So it's a bigger reward if we do a good job for these people long term. Side effects for head and neck and salivary or parotid specifically, but for almost all head and necks, it would be erythema, trismus, osteomedia. That's where you have like the pain right here in the ear area, hair loss, erythema, desquamation, and dental problems in the future. Again, severe erythema would be avoided if you could avoid at least one parotid gland. Um, or if you have two parotid glands involved in the treatment, bringing down the dose the best that you can, so you can spare as much of the parotid from um, destroying it with radiation. That's very important. Again, the more we radiate a parotid gland, the less likely it's going to be able to produce saliva, and the more effect it's going to have on a patient. Okay, so we are done with salivary. We're done with head and neck. We'll take a 10-minute, actually come back at 8:45 and we'll do I have a practice shift sheet and then we'll go on to lungs. So I'll see you guys at 8:45. All right, let's see if I can share the screen. Okay, for your homework assignment versus the one we're going to go in class, I want to just briefly mention this part. Your homework assignment, this is the one we're going to go over in class, and this is the homework assignment. Um, the homework assignment, it is a KV pair, meaning this was taken at the exact same time. I know that because my ISO center lays at the same spot. So on a KV pair, I shoot an AP and a lateral 90 degrees apart, and that's how I get those two. So these are the same images on a KV pair. Just because this one that I'm going to show you today in class is not a KV pair, I know that because this is obviously not in the same spot of the body. I know that because I can just count my graticule. Okay, right here, my graticule to the top of the lung. Oh, my mouse is running out. Is 5, 10, 5, I'm sorry, 5, 6, 7. So this is 7 to the top of the lung. And on this one, I can count 7 and I'm not at the top of the lung. So I know that these were taken independent of each other. So basically, I didn't get shifts or the patient lost their marks, and I can go in and say, well, I'm not going to take a KV pair because I know I'm off. Which one can I decide that I'm going to be closest one? For me, I'm a big fan of looking at an AP on a lung, but some people are much more happy to look at a lateral. There's no right or wrong to that part of the answer. So I will probably shoot an AP and just make sure I'm closer before I get to the next one because I don't want to radiate another area where I shouldn't be. So all I want to point out is different from what I'm going to show you in class to the actual homework assignment. Is your homework assignment's a little bit easier because this person did come in with their marks. I was able to make shifts, and I was able to take a KV pair on it. So these are sitting in the same spots. So the shifts would be the same. All that just to say that these are not a KV pair. So let me close this homework assignment. Move this one up. All right. So let's start with Clarice. This is image A, this is image B. The patient is head first supine. Your DRR is going to be, this is your DRR. Locate the initial reference point on the CAX. The MD wants to shift the initial isocenter, which is going to be blue in this case, to the new isocenter in green. So this is where you took the film, but this is actually where the isocenter should sit. Okay. On question 1, which one is your AP image? Image A or image B?
B.
Okay.
Do I still answer?
Yeah, that's okay. I was like, I don't even think that was her voice, but
I was gonna say B as well.
Sorry.
okay, good. I don't know. So thank you. Dariana, let's do number 2. Which one is the lateral image? A or B?
A.
Okay, good. Okay, on then image A, we have Rebecca. Which one is the anterior or posterior? Where my cursor is right now, would that be anterior or posterior on this patient?
Anterior.
Good. Yes. Don't get mixed up because the last one showed that on this side of the screen. Basically, just look at your anatomy. At the end of the day, just look at your anatomy. This is my spine. This is my spinous process. This is where the lung sits. I know my spine sits posterior. This is my body and this is my table. So this has to be the posterior part of the patient because that's where the spine is. So then I just want you to continue to read. According to the new shifts, please answer the following questions based on couch movements from the lateral KV film, which could be different than the AP because these are not KV paired. So just read the instructions. On the lateral film, based on couch movement, so this one right here, would you move the couch in or out? And Diego had a great video. Did he send it to all you guys? Yeah. I really liked it. I think I'll show it in one of my classes next year. But you can do the pen, you could do Diego's method. In this specific one, if you're starting with blue and you're gonna go to green, how would your table move? Desiree.
Would it be in?
So put your pen on the blue,
Let me
and
get that.
then you could even just draw this. And then how do you move? You can't move your pen. All you can move is the paper. So you want to go from, you're starting at blue and you want to land on green. How is your table going?
Okay, yeah, it is going out.
Yeah, good. Does anybody not see that?
Sorry, I had to actually like write it and do it.
Okay. And do you write it with the air or how are you writing it?
Well, I'm writing it. I have both of the crosshairs, and then I'm, like you said, I'm moving it and
Perfect.
then just moving the paper.
Yeah. So again, I don't think I have any of these on the exam. I'll know for sure tomorrow when we do exam review. Bring a paper, bring a pen, bring a clear transparency, whatever you want. We record your exam, so I'll know if it's inappropriate. Bring the things that you want and then move it this way because it is easier to visualize it when you could actually move it. But I want you to understand that what is moving is the table. It's not going to be the ISO center because that's in the gantry and that doesn't move.
Janae,
Okay. Yeah.
can we use our Diego method on the exam?
You can use the Diego method. Yeah. So bring a clear one if you want. Yeah.
Like even with our little guy, like our paper guy?
You can bring a paper guy, but it's not going to work on the lap. But yeah, you can bring a little guy that looks like that.
It works on the lap for me.
Yeah, it
Okay,
worked on the lab
perfect.
for me too.
Okay, okay.
The Diego method.
Okay, then you're right. It doesn't work on the lap, but the little stick figure. I guess you can move the gantry that way. Yeah, you can
Yeah,
bring a stick guy. Yeah, bring a stick guy. Bring the Diego method, or bring a pen and paper. Draw it out. Whatever works for you. I will know. I mean, and you could just show me your little paper and say this is what I'm using. All that's okay. And honestly, there has to be a level of trust here also because this isn't just to get a point on an exam. This is so that you understand it in the clinic. So if you're going to cheat yourself and you're going to cheat me, you're going to cheat your patients, and all of that is bad. For Megan, which of the planes would you be affecting if you moved the table out X, Y, or Z?
Oh, sorry, I was muted.
Oh.
If we move it out, we're doing Y.
Perfect. Okay. Um, Abby, would it be positive or negative?
Going out would be negative.
Perfect. Okay. Um, Patrick, let's go back to this lateral DRR. Now, would you be moving the couch up or down? So if you have your gantry is situated on the blue and you need to go to the green, would it be an up or down movement from the table?
Up.
Um,
Oh no,
no,
down. Yeah.
yeah,
Sorry.
yeah. So the lateral's a little bit easier for me to understand. I could do it with Diego's method. I could do it with a pen. But for me, whenever my patient is head first supine and my ISO center is going anterior, the only way to get anterior is to bring the table down. Okay.
Yeah, that makes sense.
Okay. Um, Sterling, would it be positive or negative if you move the table down?
Negative. Quite, yeah. Right. It's not negative. It's negative.
It's positive. So when your table
Oh,
is going down, you're going positive. It's inverted.
okay.
Janae,
Yeah.
so I just wanted everybody to know, I remember all the positives are RID. Like RID is, I don't know why RID is positive, but right and down are all positive. If you guys need that for the exam.
Okay.
RID. I don't know if it helps.
Thanks.
As long as that works, you definitely people. I'm an acronym person also. Whenever I take a test, I make a ton of like funny sayings that I'll remember. Um, it's not because I'm trying to memorize everything, but it's just once you establish the basics of it, and this is what I mentioned after class yesterday. Memorization is not bad. So I don't want you guys to think that to memorize that when my table goes down, my numbers go up is bad. It is actually helpful because then when it something is like out of the ordinary, then you can understand why. So almost all the time when my table goes down, my numbers go up. Memorizing that as like a concrete fact is a good idea, and then you could basically around that understand why that's happening. So I do like to begin with memorizing things, and then afterwards I try to understand the concepts of why I'm memorizing what I'm memorizing. That's good. Okay. Oh, this, and then I want you to understand this concept also. Okay, take a moment and think about these images. If this was a KV pair taken at the same time, this one wasn't, but let's say it was. Let's say you took a KV pair, and you wanted like the most bang for your buck. You knew your SSD, so your vertical was great. Okay. And so you were like, but I feel like I have two other planes that could be off. So this image pair is taken at different times. So the AP and the lateral are independent. But if it was a pair, which axis is visible on both images, vertical, longe, or lateral? Zena.
I'm sorry, can you repeat the question?
Yeah. So if I needed to move, which axes could you shift from here? So basically the question could be asked, I'm looking at the AP right now. Can I move my lateral from this film?
Yes.
Yes. Okay, good.
Okay.
Can I move my vertical?
No, that would be A.
Good. Right. Okay, good. Can I move my longitudinal?
Yes.
Good. Okay. So same with this one. Can I move my vertical?
No. Or sorry, yes.
Good. Can I move my lateral?
No.
Okay. Can I move my longitudinal?
Yes.
Okay. So which axis can I move on both of these films?
Longitudinal.
Perfect. Yeah. So I can make a longitudinal shift from either of these films. All that to basically say, if I'm asking for a longitudinal shift and it's a KV pair, pick the image that works best for you. Pick the image that you can see more clearly, that makes the most sense for you. Longitudinally, you can shift from either one of these. Again, I'm an AP person, but a lot of people like the spine because they like to sit in the inner space, or they're like, oh, I can like really see this area right here around the spine. Lots of people like to use that portion of the spine. I do too in some cases, but for me, the bigger picture of an AP, when I'm looking at something, this to me is super clear. Like I know this is my humeral head, this is my scapula, this is my lung, this is my heart, this is my spine, this is rib 1, this is rib 2. I know that this is my PA rib. I'm pretty good with anatomy and I look at anatomy all day. So for a quick moment for me, it's like, yes, this is my AP. I'm going to be able to very quickly go where I need to go. and then I can fine tune here from my lateral. So I'm a person who looks at AP, but that doesn't mean it's right or wrong. If whatever makes the most sense to you, that's what I want you to go with. I know that this right here is the bifurcation of the carina. So I have a lot of because this is all I do is look at x-rays, I have a lot of things that I can reference and quickly pinpoint going through my head. Whereas the spine, I'm like, okay, what this is spine. Okay, maybe this is T7. I don't know. Let me see if I can find like a protrusion. I know once I lock in here, then I'm going to be very close and I could fine tune it with this inner space. So if there was a question, Danielle, is it Danielle or is it Danielle?
It's Danielle.
Okay, that's what I thought. Sometimes the extra E really throws me off. So, Danielle, the one axis that we can move on both of these, AP and lateral, is it an X, Y, or Z?
Y.
Perfect. Okay. And then Ashley, what's the treatment site from this DRR?
From
From,
that DRR,
yeah,
it's
from
going
this.
to be the green, so it's going to be left lung
Okay.
or rib.
Right, right. I agree with all that. Lung definitely would work, rib would also work. So very good with that one. Sydney, what do you think this was treating? And this could be a lot of things, but just guess. If your isocenter sat right here, what do you think you would be treating?
The spine?
Yeah, so this could either be posterior lung. This could also be spine. This could be a number of things, but I just want you to know that the option that this is multiple things is there. Like just because your isocenter sits on the spine doesn't always mean it could definitely be a posterior lung. I've seen posterior lung sit right here. And I've also seen spine sit right here. So either one is a good answer. Okay, let's get into lung treatments. Okay, anatomy of the lung. So I mentioned previously that I could see a lot of this in that last x-ray. The bifurcation of the carina is something that I very much like on that last x-ray. It just generally shows up dark. It's just a little tree, it bifurcates. It's something that can very easily be seen on an x-ray. So I generally use that as one of my go-to points when I'm making sure that I'm locked in on the right area. Another reason is because a lot of tumors like to sit right there near the bifurcation of the carina, and so it's one of my go-to, like, okay, am I hot or cold on the bifurcation of the carina? It's one of the areas that I'm looking at. You have two lungs. The right lung has 3 lobes. The left lung has 2 lobes. And that's because the heart sits right here in this space. Fun fact, so just said it, but the right lung is divided into 3 lobes, and the left lung only has 2 lobes. The bifurcation of the carina is located at T5. The trachea branches into right and left mediastinum and bronchi at the level of the 5th thoracic vertebrae. I think that's on boards. At one point it was on boards. They just wanted you to know that the bifurcation of the carina was also located at T5. So I would put a little note on that. I don't know if I put it in an exam, but if it's on boards, I would have tried to get it in an exam. The lungs are separated in the midline, so they're very central. They're separated by the sternum, by the mediastinum, which is composed of the heart, the thymus, the trachea, the great vessels, the esophagus, lymph nodes. Mediastinum can be divided into superior and inferior compartments. We'll talk about that quite a bit in a little bit, because we want to know what moves when we're talking about lungs and what becomes more stable. All of this to say that the lungs are an area in which we do radiate quite a bit. There's a lot of important things that sit not only inside the lungs, but around the lungs, and the lungs are quite movable. So how do we go around all that? How do we do a really good job treating lungs? And we do a really good job treating lungs. And how do we get there? First, we need to know how lung cancer spreads. The primary route of tumor spread is usually lymphatics. It can also be blood vessels and direct extension. And we should just know that small cell lung cancer has a higher rate of distant metastases. That means metastases elsewhere in the body. Small cell lung cancer has a very, very, very high rate of metastasizing to the brain. We used to treat the brain prophylactically, meaning we were almost sure this person would get brain lesions if they didn't already have them. So we just treat the brain right after we treated the lung, even if they didn't have any active diseases. Now we don't. We don't, because our brain treatments, along with our lung treatments, have gotten so darn good. So we no longer really treat the whole brain. If the patient from small cell lung cancer does metastasize to the brain, that's okay. We'll SRS it. We'll catch it early. We know it goes there. We're going to be watching it, waiting for it to go there. And we're going to treat it very, very small lesions at a time, probably for the rest of their life. And that's okay. We're going to, instead of necrosis of the brain, instead of having them have memory loss and all those side effects that are associated with that treatment, we're going to just treat it little bits at a time and give them a better quality of life for the remaining life that they will have. The technical aspects of radiation therapy. The reason that we're not going to go through the book for field sizes and field borders on lungs is because it doesn't look like that anymore. I don't even think I have a... Yeah, I don't. So there's no field borders specifically on lungs. It's not going to say the top is here, the bottom is here. And that is because it varies. It's based on the size of the tumor, lymph node involvement, and then the margin, the positive margin of tumor and what they see on diagnostic scans. The treatment design is based again on the primary tumor, its location, and lymphatic drainage. Treatment portals are usually designed with a 2 centimeter margin around both the primary tumor and nodal areas that are involved at risk. 2 centimeter is generous. We don't necessarily do that anymore, and we definitely don't do that on SBRT. Most of what we're going to be seeing in the clinic, along with brain, because we've gotten so good at these, is probably 1 centimeter to 0.5 centimeter margin. And that's because the more healthy lung tissue you radiate, the long-term side effects these people are going to have. Before, we needed 2 centimeter because we were breathing. I mean, we were breathing and we didn't have a way to gate it, and we didn't know. Our fear was that this person could take in a big breath and the tumor would be outside the PTV and we'd miss it. Now we really have a way of localizing and gating these lung tumors to make sure that they're in target all the time. And so our margins are much smaller now, specifically for SRS. We're really good with SRS lungs. Okay, simulation. What does a simulation setup look like for a lung? Alan, did you see a lung? Was it IMRT, 3D, or SBRT?
The lungs I saw, I did see a couple of them. I know, I want to say at least one was SBRT.
Okay, that SBRT specifically, how'd you guys set it up?
It was wingboard with headrest and arms overhead, and I want to say just pad and knee wedge.
Okay. Did you
Yeah.
gate it?
No, we didn't gate any of our lung patients. Only 2 breast patients did we
Okay.
do that. Yeah.
Hector, did you see any gating?
Yeah, we did quite a few of those.
And what product did you use?
I can't remember the name of it right now.
So there's either RGSC, which is the frog, the beacon, or there's Vision or Align RT.
Vision. Yeah,
Okay.
Vision.
Okay. Can you talk me through what that looked like?
Like for the gating?
Yeah.
So it was like it's like a 2 systems that are used, and this black box that gets placed on top of them. And from there, you kind of set it to how deep you want them breathing, or like where you want to cut off the peaks and valleys of it.
Okay, good.
And then
That's
based on that, it's like how shallow they can or can't breathe, depending on what the doctor wants. Sometimes they want like a deep breath. Sometimes they want them like during exhale. So it depends on like what the doctor wanted during sim.
good. Okay. So that's what I want to get into a little bit in this class, the different types of gating that we do and why we do it. Again, radiation therapy techniques, margin around the GTV would be 2 centimeter. Very, very old school way would be APPA, or a very palliative way would be APPA. And then again, anytime we treat anything APPA that can be close to the spinal cord, we need to get off the spinal cord at 4,500 gray. Then you can do 3D, IMRT, and SBRT. Most of what we're going to see is going to be IMRT or SBRT. The dose escalation on these, it's all over the place because there's so much research being done. Depends if you're in like in an academic center or a clinic. What it looks like to have a 1 treatment versus a 3 treatment versus a 5 treatment SBRT. What it looks like to have 12 versus 18 versus 35 treatments for a lung. So you will and probably you can and probably will see all of this throughout your clinics. Again, there's no wrong way to do it. The alpha beta ratio on lung tumors basically just says if you can minimize the more you can localize the tumor and minimize the margin around it, the heavier you can give the dose. So if you feel really secure with your setups, if you're using RGSC, the frog, the beacon, or if you're using Vision, or if you're using Align, or if you're using Identify, if you have something that does a really good job gating and you have this intrafraction imaging that you can verify that with, you're going to feel really good about giving 1 or 3 or 5 treatments or even 12 treatments in an IMRT setting to a lung. If you don't feel good about it, you're going to go more safe. The more safe method is 180 a day, and you will go longer, and that is because you want the ability of the healthy tissue to repair itself during that process. You're not going to hit it hard. You're going to go slow and steady. And there's nothing wrong with either of those ways. Okay, motion during a lung tumor. Because we have motion in inside of the body, we need to have an additional volume. That volume is called ITV. There's definitely on the exam, I want you to know what a PTV is, a GTV, a CTV, and an ITV. All those volumes should be very clear to you. The ITV specifically means that there's the opportunity for motion to happen inside of the lung due to breathing. And what does this mean? What kind of margin am I going to give this volume to make sure that I'm not going to miss it? Let's see if I can find this video. Okay. So here we can see the lung. Specifically, what I want us to see with this lung is the areas of motion. Okay. This helps us understand in the clinic what we're looking at. Zena, you have a question?
Yeah, so is ITV always going to be in between CTV and PTV?
No, ITV is going to be the last one.
Okay.
Okay, so it's GTV, which is gross tumor volume, CTV, clinical margin, PTV, planning margin for inconsistency with setup. And then you have the last one, the fourth one, which is ITV. So even if all those other things were perfect, even if I have gating on this patient, there's still a chance that they're breathing differently. So that gives me a little cushion for that specific type of area. Every body part, let's say it's my leg. My leg doesn't have any motion with breathing, but I'm going to have a GTV, CTV, PTV, but an area that will be moving because of internal motion, let's say bowel movement, diaphragm movement, breathing movement, that would have an additional ITV. It doesn't have to be large, and hopefully it's not large. Hopefully it's small because hopefully we've done a really good job gating this.
Thank you.
Mhm. What I want us to look at from this specific video is the areas of the lung that move the most. Okay. If you're sitting there on the linear accelerator and you have a lung and you're like, I'm so surprised this doesn't have any gating on it. It should have gating. It's a lung. Well, is it an upper lung? Because if it's an upper lung, more than likely it doesn't need to have gating. The lower part of the lung has the most motion. And I want you to look at that from this video. And that is because this diaphragm is what is moving. That is what is giving us the airway. When I get a lower lung tumor, I'm almost always going to expect that there's gating on it. When I get a midline tumor, it can go either way. When I get an upper lung tumor, if there's gating on it, it's because the doctor wants to be super particular. But generally, I do a lot of 4D scans. I know from my 4D scans, when I'm looking at the specific tumor on the upper, it's not really moving. It's not moving at all. So if I would have a question and it says which tumors are going to move more, an upper lobe tumor or a lower lung tumors are always going to move more, and that is due to them being closer to the diaphragm. Let's see this video. Actually, I remember what this is.
Respiratory gating is a big term that can be broken down to a simple idea. This allows doctors at Martha Jefferson Hospital a more precise way of treating cancerous tumors in some parts of the body. By tracking your breathing, it can track a tumor in your body that's moving. This has potential for a couple of benefits. First, though, here's a more in-depth look at how it works. We've got a machine here that treats radiation. Delivers radiation to mostly cancer patients, and it can do all types of tumors, and basically any site we want. And respiratory gating is a small part of what we do with this machine. How is it different from normal radiation? Right, normal radiation would just turn the beam on and the beam would stay on during the treatment, and we would turn it off as we reposition to treat from different angles. Respiratory gating is a mechanism to deliver more precise treatments. It's actually a small marker block that would sit on a patient's chest, and we've got a little camera that watches that little marker block breathe up and down. So the machine knows that the patient, the breathing phase, the breathing cycle of the patient, and so therefore it knows where the tumor is. So if you've got a tumor moving in and out, the machine actually knows where that tumor is. So it can synchronize and turn the beam on or off as the tumor is in the right spot. We all breathe at different rates, or sometimes you have to cough, or so the machine will actually turn itself off and wait until you're in a regular breathing pattern again. Knowing that, we can actually customize the shape of the radiation to the target. Why would everyone use this? A lot of times we image and the tumor is not moving that much, and if it's not, then we don't have to worry about it. And if you're an erratic breather, this won't help you. It would be too jumpy for the machine. Respiratory gating may reduce damage to tissue surrounding the tumor, and there is the potential to increase the dose of radiation because it's more exact and more accurate. Cancer treatment may be improved by some advanced technology based on taking a deep breath.
Okay, so do I have any images of this? I don't. I would like to do a cine wave with you guys, and I would like to have you better understand this concept. So I'm going to work on that in just a few minutes. But let's go through some of these slides and then we'll take a break and then we'll do that and then we'll do case studies. So during the treatment of a ITV, during the treatment of a lung, an ITV would be generated during planning to account for motion and breathing. What are different ways that we can account for motion and what are different ways that we can control motion? So we can do breath hold control methods. So if you're using a breath hold technique, that means that you're asking the patient to take in a breath and hold it. Or you're asking a patient to take in a breath, blow it all out, and hold it out. The patient is controlling what they're doing. We're gating the beam, so if they don't match it, it doesn't beam on, but the patient is controlling it. There's also respiratory gating techniques that are called amplitude gating. That means the patient is just living their life. They're just sitting on the table and they're just breathing, and they don't actually, I never let them know they have control, because the second you tell somebody breathe normal, they're not going to breathe normal. So I just tell them, okay, be nice and relax. We're just going to take some imagings. I don't tell them about their breathing at all. I'm going to let them breathe in, breathe out, breathe in, breathe out normally. And then I'm going to let the beam on and off according to what the doctor has prescribed. So those are the two different types of methods, the method of breath hold versus amplitude gating. Let's go back. Let's do this one real quick. Varian has the RSG RPM system. That's the beacon system. They call that black box a frog because they say it looks like a frog's face with two little eyes. Basically, that box is a surrogate for what breathing is. It sits on your abdomen area, it sits on the diaphragm area. And when you take in a breath and you breathe out, it's detecting that. It's not 100% accurate because it's a surrogate, meaning it is not in the actual area that we're treating. We're just trying to understand what's happening inside the lungs by what's happening on the outside of the body close to the diaphragm. That being said, a little bit more precise would be the vision, identify, Align RT. Vision and Align are the same thing. But those products, therefore, would gate the chest area, the skin rendering. So when you're taking in a breath, you have a better understanding. But like I think it was Alan said that he's seen that for breasts versus lungs. And that is true because when you're treating a breast, you're treating the external part of the body and that skin. That skin is attached to the breast. And so it is in that case, skin rendering technology is very, very good for breast. Now, for lungs, it is better, but you still need to image. You still need to image because the lung is inside of the body, and I can't actually see what's happening to that lung, to that tumor specifically. And inside of that lung, the tumor can move just according to growth, according to how you're breathing, what it's looking like that day, what's happening to it after treating. So imaging is incredibly important still with lung tumors. So having a gating device and imaging, they can't be replaced. One can't replace the other. Amplitude gating. So I mentioned breath hold can be inspiration, take in a breath and hold it. Basically, you're stabilizing the diaphragm. What I'm doing is I'm taking that diaphragm and I'm taking in a breath. And when I take in a breath, my lungs fill up and it's holding at the inferior portion of the diaphragm and I'm just holding it there. So I'm preventing this motion of breathing and I'm holding. Okay, the patient can breathe. I'm not going to beam on. So I minimize the motion by having the patient stabilize their diaphragm. Expiration is the opposite. The patient's breathing. I want them to take in a breath. Then I want them to blow out. And now when they blow out all of their air, their diaphragm is going to be pushed up because there's less air into their lung. And they're going to hold it there. So you're stabilizing it again. I haven't gone into this lecture yet, so I'll just give the answer now. But when I'm thinking about a lung treatment, generally, I'm thinking about inspiration. I'm thinking about inspiration because I want that lung to be stretched out. I want to give me more room. I want to give me more room to work around, just like everything I do in CT SIM. I want to extend the neck and the shoulders to give more room to work around, give more angles. Expiration generally doesn't work for me because it's pushing it up and it's pushing the diaphragm, possibly, and the things that sit under the diaphragm, like the liver, like the kidneys. I'm pushing all that closer to the tumor. So when I have a person taking a breath and I'm able to push those body parts away by using their own breath, that's how I'm going to maximize my dose to those lung tumors, specifically the lower lung tumors. Expiration, I only mention it here. Expiration, I love in abdomen work. So if I'm doing a liver, if I'm doing kidneys, if I'm doing a stomach, expiration generally works for me for those areas. The expiration phase of breath hold is difficult for patients. So oftentimes what I'm going to do when I have the expiration, I'm going to do it with the amplitude gating, and the treatment is just going to be on the expiration portion, which we call the 30-70 portion, 70-30. That is the expiration portion, because as a human being, you could all just try it here in class. We're used to this. We can take in a breath and hold it. We've been playing this game since we were a kid, but taking a breath and blowing it out and holding it out is difficult. And it's difficult to do while not shaking, while not moving. So this one is much more difficult, although you'll see clinics do it. It gives a better treatment. It gives more work. It's just more difficult for the patient. And then as far as amplitude gating, you have where you just take the phase of that gate. So you take the, I'm going to go into this in just a few minutes, but in the cine wave, it's peak to peak, which is 100%. You're going to take that percentile of the peak, and that is the area in which you're treating. So if you're treating all phases, if you're doing all phase gating, that means that you're treating the entire time. So if I'm doing all phase gating and I just have the top and the bottom, all I'm doing is making sure that that person's either A, not going to move, or B, like if they cough, it'll go outside. It'll prevent the beam from beaming on during all phases. So basically I'm just top to bottom of the cine wave. And I'm going to find a video real quick, or I'm going to draw it after this lecture when you guys come back, to make that makes a little bit more sense. Organs at risk. Organs at risk that must be contoured during the treatment planning generally include lungs, that area of treatment. This is a good question. I got an email on it. It's on the TD55s on the organs at risk. If you have like a lung, if you have a brain, should that organ be involved? Yes, that organ should be in the critical structures for what we're looking at. You should know the TD55 of the area that you're treating, specifically areas like lung and brain, where you have like, if you treat 1/3 of it or all of it, it does change. Know that the area you're treating is also important. You're treating the tumor and trying to minimize the area that you're treating. You have the heart, spinal cord, esophagus, liver, and brachial plexus. So if it's if it's a lower lung tumor, I don't want you guys to put brachial plexus on there as like an area that could have side effects or an organ at risk, because it's not an organ at risk. Do know that the lung is a large area and what would be involved in that specific area. This is an illustration of a patient who was treated again. Oh, this is good questions. Okay, Diego, this gray right here, would you call that, if you had, there's no ITV on this, so let's make life easy. It's either GTV, CTV, or PTV. What is the gray?
GTV.
Good. Clarice, what is this salmon color?
It is PTV.
Good. It's PTV. Yep. It includes the GTV, CTV, PTV, and then if there's one more, it would be the ITV. So here it's just a good example of, this would include probably the brachial plexus, because I could see my sacrum right here. I could see my ribs. So I know, I could see the heart. I know that this is upward on this person's lung. because I could see the shoulder and the scapula on both sides. So if it was the lower part of the scapula, I know it would be just a little bit lower. Here's the sternum, the spine. On this particular case, if I was lining up, I would really be lining up to spine specifically. And then I'd probably throw on a lung window on my CT and then go to tumor specifically. But I would want to make sure that it's so close to the spine, I would make sure that I wasn't getting too hot to the spine. This is a really big field. I've not seen a field like this in a very long time. But this is how we used to treat lungs. This would be, it's MLC, so I'm assuming it's IMRT in like a 5-field kind of treatment, but this is huge. And you could see how this specific tumor and this specific field is getting into the spine. So these are what we're talking about, how we used to treat lungs. And why we would need to get off of the spine at 4,500, because this is how big our fields used to be. Those of you guys who have seen a lot of lungs, specifically SBRT, but even just lungs in the clinic, you know now they're really small. They're really small what we're treating. We're treating like this compared to this. Small cell lung cancer, it is sensitive to chemo, which is good. So we generally treat them hand in hand with chemo. We could do, and so that's something else we need to think about. If they are on chemo, how are we scheduling this? Are we orchestrating it to start it on the same day? I think they get chemo once a week. So on that specific day, maybe we need to schedule them a little bit later in the day, our first thing. So it's a little scheduling sensitive with us to make sure that we're able to get them all the things that they need to do the best outcome for their treatment. Their dose is, this one could be small cell. It's sensitive to a lot of things. So it could be 4,500 gray, or sorry, 45 gray in 1.5 gray, a fraction BID, 6 hours apart. Or you can do it 50 to 70 gray in 1.8 to 2 gray, and that would just be once a day. Let's see, this page 218. I'm going to look at what page 218 is in a second. Non-small cell would be your primary, your lymph node involvement. These are a little bit more resistant. So we treat these to 63 to 66 gray, 1.8 to 2 gray, a fraction. And SRS, again, we have a lot of dose fractionations, but 20 gray in 3 fractions is something that you can see. You may see 5 fractions, 3 fractions, or 1 fraction for a lung. And it just depends on what the responsiveness of the tumor and what that dose is going to look like. So it's probably going to be all over the place from what you're seeing in the clinic. Oh, this is prophylactic cranial radiation. Again, we used to treat small cell lung cancer. And then on top of that, on top of the regular big field, this field to the lung, we used to also treat the brain with it, because we knew that the odds were very high that it would metastasize to the brain. Again, if you did that, which we don't anymore, but if you did do that, the dose would be 10 fractions for a total of 25 gray prophylactically to the brain. These are more like what we see previously. Let's say 10, 15 years ago, we used to see this. On your linear accelerators, this is even a big solid bulky tumor right here, but you're going to see something more like this as an IMRT treatment. Generally, this is an SBRT treatment for this. It would need to be much smaller for it to be here. It also just sits pretty close to the spine, and it's so big that I would say that this one probably was an IMRT, but I never remember where I'm at. Megan, would you say this is an upper lobe tumor or a lower lobe tumor? And how would you gate it?
Upper lobe.
Okay. Would you gate it?
No. I mean,
Yeah. I would do a 4D CT, but I would like, just so they can see. But more than likely, when I do a 4D CT and I play it back for them, they're gonna say, "Oh no, we don't need to gate this."
because
Like
it's
just
not lower.
right, because on my 4D CT, I'm doing the fourth dimension, which is motion. And so I'm able to see it when I play it back, and they're gonna take out the little measuring tool and it's really not gonna move. Just from my experience, I would, and it seems like it's for me, this tumor seems like it's attached, meaning that it's just not floating in space. And so when it's attached like that, it's probably not moving. From my experience, I would say I would 4D CT this because I do that for all lungs. They probably, and it's good. You would want to know if it's moving. But more than likely, when this goes on the LINAC, this is not going to be gated. Dose limiting structures. To know these tolerances doses, spinal cord 4,500, lung 4,500, esophagus 60 gray, heart, I'm talking gray for all these, heart 60. And then has anybody had any experience seeing a pacemaker on a LINAC?
Yes.
Oh, good. What'd you do?
Nothing. I got to watch or I heard about it. I heard the physicist went in the room and put the diode, I think, to measure the dose.
Okay.
And then they quizzed me on it. They said, "What's the tolerance dose?" And I looked it up and I saw that it was 2 gray for a pacemaker.
Is it? Let me put that in there. I actually didn't know that. So okay. Okay.
Yeah.
And what body part were you treating?
I don't even remember because it was a different treatment room. I think I must have been helping the other side, and then once I realized, it was like they had already placed the diode and had already started treatment and everything.
Okay, good. I'm glad somebody saw it. The pacemakers, they can be dependent or independent, so that's where we start. And that basically means, are they going to defibrillate somebody if their heart stops or if they're tracking? That is a question that is asked in the survey. When a patient has a pacemaker, first question that I think of is, well, where am I treating? Okay. If I'm treating a prostate, fine. It doesn't really matter. I've been at places where I treated prostates. They had a pacemaker. We put a magnet on it. Basically, we just didn't want it to defibrillate and get destroyed by the radiation. So basically, a magnet just pauses it. It's just like a little round tube that sits there, and then they would go get it checked after each treatment to make sure it turned back on after the magnet. I don't see a lot of magnet work anymore. What I see is what Alan saw, which is they put a diode on it. But all that to say, if it's a lung, it's getting radiated. So what do we do about it? We need to know, and the physicists and the doctors need to report how much radiation that's getting. So what they do is they put a diode on the pacemaker, and then what I do as a therapist is I do my best not to radiate it. Now, if it's this patient, I'm pretty out of luck. My pacemaker is going to sit right here. But if it's a lower lung tumor and the person has a pacemaker, I have a lot of options with my CT. I can longitudinally shift in so that I'm giving as little dose to that pacemaker as possible. I could spotlight, maybe get a little less dose to that pacemaker if I could. I have options. Now, my treatment's not going to be on top of the pacemaker, more than likely. Your physicist and your doctor probably work pretty hard to make sure that actual treatment isn't going to involve that pacemaker. There's going to be scatter, attenuation, all kinds of weird things that are going to happen. So they've probably done a really conformal treatment. But what can I do? I have control as far as the imaging portion of the treatment. So yeah, I would probably longitudinally shift this person and try my best to get off of this pacemaker just to give them the best outcome with a pacemaker as possible that I can. Those are just good ideas. The goal again is to not radiate the pacemaker as much as possible. And if it should be on your CT form, on CT simulation, you should know this person has a pacemaker. If not, you you're looking at your CT. So you should be informing the doctor, hey, this person has a pacemaker. And they will also see it on the CT set. So all these are important to know when a person has a pacemaker. It is radio sensitive. You do need to do your best to get off of it. At the very bare minimum, knowing there's a pacemaker there, everybody should know. Everybody in the department should know, and you should know whether you're dioding it, what you're doing about it. So the pacemaker is something that we think about. Brachial plexus, that is just, we're thinking about that when we really get into it when we get into breast, but it's just the plexus right here. We want to get off of that. We can cause inability of joint movement, and we don't want to do that. The liver and the kidneys, if it is a lower lung tumor, would be something that we are concerned about also. Oh, this is a good one. This is a trick question. For a patient getting treated for lung, what diet would you suggest? You can put it in the chat box. And I'll tell you my if a patient asks me this, yeah, perfect. If a patient asks me, oh, do I need to do anything with my diet? I would say no, keep doing what you're doing, because I really don't want to change things up. It's already very stressful for them. But yes, a balanced diet. I don't want them to go on a diet. I want them to just eat normally. I want them to eat and drink. I don't want them to not eat, because I need them to have protein. I need them to have a nice balanced diet to get to the treatment, just to heal normally. But there's no dietary restriction for lung tumors. Okay, we're going to get into SVC real quick. SVC is superior venous cavus syndrome. It's a medical emergency. We have very few of these in our field, meaning that spinal cord compression and SVC are probably the things that if you don't treat in, like, let's say the next 24 or under hours, these people could have major lasting side effects. Or possibly die. Superior vena cava syndrome is a medical emergency occasionally seen in patients with malignant neoplasms. It requires immediate therapeutic action. Again, this is one of the true emergencies in radiation. The dose for these is 3 gray or higher daily, 2 to 3 days. I'm saying 2 to 3 days, and that's because initially you give a very high dose for 3 days. They're very radiosensitive. We do a really good job in radiation shrinking these, but basically it's going to sit right there on their airway. They're gonna have a hard time breathing. They're gonna have a hard time laying down. So after 3 doses of 3 gray, it has shrunk quite a bit, and then therefore these people have a lot of relief. They're able to lay down, and then you're able to make a mask and do all the things that you would need to do to make a better, more conformal treatment. But instantly, those first 3 treatments, they're there just to shrink the tumor. It's really palliative at that moment. You want the primary tumor with a 2 to 3 centimeter margin to also include the mediastinal, hilar, and supraclavicular area. So it's a pretty big square field. It's something on the weekend you just create really quick. You're just shrinking that to make sure this person's able to breathe through the weekend. Okay, the side effects of radiation to the lung. This is a large field, and it's a large field of a lot of important things. So you can have acutely a cough late because of the large field. The more lung you get in there, the higher chance of radiation pneumonitis. That's inflammation of the lung. It usually happens 1 to 3 months after radiation. You could have pulmonary fibrosis, that's scarring of the lung tissue that makes it hard to breathe. This can happen 4 to 12 months after radiation. And then long term, you can have esophageal problems and then pericarditis. It's like basically in this area of SVC, you have the lung involved, the esophagus involved. a large portion of the lungs. So as soon as you can get some relief and get this person so they're able to breathe and lay down and get a more conformal treatment, the better off you're going to be. We will take, we're doing really good, right? Okay, we'll take a 10-minute break. Come back at 9:55. I'm going to see if I can find a video or draw a quick video of the amplitude gating, and then we'll go into case studies, and then we'll be done. I'll see you guys at 9:55. Okay, unfortunately, I couldn't find a video, so I have to draw this. I'll wait for a few more. Click on it. Okay, so what this looks like is hopefully it looks similar to what you guys see on the Lennox, where you have your gating monitoring. Okay, this is a cine wave. It just means a wave that goes up and down according in a cycle, according to breathing. So expiration, inspiration, expiration. This is 0. Okay. This is my baseline. At the end of the day, I would love it if everybody sat and their expiration was at 0, because that should be my 0 point. You can see when people fatigue and they start to dip lower, or when it's learning their breathing pattern, sometimes they're breathing a little inconsistently and this changes. But at the end of the day, I want my baseline to be at 0. If this was a breath hold, it would look like this. And then I would tell this person, okay, what I'd like you to do is take in a big breath and hold it. And they would come up and they would hold it and hold it right here. And I would have my gating here. So this would be my parameter. So I would want them to hold inside of that line. If they held too much, it would beam off because it wouldn't be in the gating area. And if it was too little, it would beam off. That's inspiration. Expiration looks similar, but on the other side. But gating, amplitude gating, looks like this. And they all say, we're treating 70-30. And most of your therapists probably don't even know what this means. But what it means is you're treating on the cine wave 70 to 30%. So what your doctor and your physicist are saying is from start of inspiration to point of new inspiration is 100%. So when I'm treating all phases, I'm treating like this. I just have 2 little outliers. And as long as the person's breathing normally, I'm beaming on. If they were to cough and it goes outside, it beams off. But this is all phases. This is 100%. So this is 0, 10, 20, 30, 40, 50%. Half of my cine wave, half of an inspiration is 50%. Then I have 60%, 70%, 80%, 90%, and I'm back to 100% or 0%, the new cine wave. Okay? So this is taking a breath, or this, I'm not telling this person, but this is what this person's doing. Breathing in, breathing out, breathing in, breathing out. So when they say 70 to 30, what they're doing is they're counting the algorithm according to all of these cine waves and saying 10, 20, 30, 40, 50, 60, 70. Okay, I'm going to go right about, I counted this a little wrong, but I'm going to go right about here to 30. So 70, it should be more like here, but okay, so 70, 80, 90, 0, 10, 20, 30. They'll be right about here. So what they're saying is 70 to 30% of that wave sits right about here. And as long as it's in this category, which is the expiration portion of a natural breathe, that is when it'll beam on. So when your physicist says, or your prescription says, we're treating 70-30, we know on that wave, we're treating the lower portion, the expiration portion of the breathing. Again, all phase, so this is 70-30, and then all phases looks like this, which means 100% of this phase of getting treatment with usually just outliners. Does anybody have any questions on what phase gating looks like? Or did you see something in clinic that you don't understand? Okay. So let's get into case studies. Okay, they're gonna say HPRT. That's what I am marking. And those attached to it. Okay, yeah, I like all these. We'll go through all of them. Okay, let's start with the IMRT. Is that this one? Yeah. IMRT lung, Mr. R. I have no idea where we are, so we'll start from the bottom. Hector, why don't we start with patient profile?
Patient profile, name Mr. R, age 81, diagnosis, malignant neoplasm of right bronchus and lungs, secondary malignant neoplasm of the brain.
Okay, good. I don't think in this particular one I showed the brain treatment that would have been done later in his treatments, but this is in line with our lecture. Yes, this guy has lung cancer and he also has malignant tumors to the brain. That sounds very normal. That is something that we would expect. This is not out of the normal for us. Alan, patient background?
Mr. R is an 81-year-old male who presented with a history of cough, shortness of breath, and weight loss. Imaging studies, including a chest X-ray and CT scan, revealed a mass in the right lung. Biopsy results confirmed the diagnosis of metastatic squamous cell carcinoma of the right lung, 7 centimeters peripheral mass with synchronous brain metastases.
Okay, Sydney, treatment plan.
The patient's treatment plan involves radiation therapy using the intensity modulated radiation therapy (IMRT) technique. The plan includes a course of radiation therapy delivered in 33 fractions over several weeks. The total prescribed radiation dose is 6,600 centigrade, with each fraction delivering 200 centigrade.
Okay, Ashley, IMRT technique.
Intensity modulated radiation therapy, IMRT, will be utilized to deliver precise and conformal radiation doses to the tumor while minimizing exposure to adjacent healthy tissues. The treatment plan will be generated based on a detailed CT scan of the patient's chest region, allowing for accurate targeting of the tumor volume. The treatment technique of amplitude gating will be used to make sure the treatment will not be compromised with any large changes in breathing patterns.
Okay, Danielle, treatment process, simulation and imaging.
Mr. R will undergo a simulation session, which will involve a CT scan to precisely map the tumor and surrounding structures. This helps in treatment planning and ensuring accurate delivery of radiation.
Okay, Zena, treatment planning.
A team of radiation oncologists and medical physicists will use the simulation data to develop a customized treatment plan. The goal is to deliver the prescribed dose of 6,600 centigrade to the tumor while minimizing radiation exposure to nearby healthy tissues.
Sterling, monitoring and supportive care.
Throughout the treatment period, Mr. R will be closely monitored by the healthcare team to assess his response and manage any potential side effects. Supportive care measures such as medications for pain or symptom management may be provided as needed.
Great. Patrick, what does this script read?
There's 2 different PTVs, for one for the right lung, one for lymph nodes. Both of them are 33 fractions, 200 centigrade per fraction, for a total dose of 6,600 centigrade. It's going to be once daily, 6x energy, and VMAT.
Good. Patrick, do you think there's 1 or 2 isocenters?
1.
Good. 1. Yep, this is all in the same script, so it's 1 isocenter. And in line with this doesn't show that there's a boost on it, so it's just very conformal, and that's why they basically SIB'd it. Okay. Oh, this is a good one, but I wonder if this is it. Abby, what is the type of treatment prescribed for Mr. R?
It was VMAT.
Okay, good. RIMRT.
Okay.
Good. Uh-huh. They're interchangeable. In our world as a therapist, I don't often hear VMAT. I do hear IMRT, but it is the same. Megan, what is a early and late side effect? One of each.
For the lung.
For the lung.
Fatigue early. Late. I want to say more fatigue.
If you say more fatigue,
Chronic fatigue.
right, it needs to be labeled as chronic, and that's how we know. So that would not be a wrong answer. Yeah, pneumonitis would be,
Okay.
yeah. Fibrosis, lung fibrosis would be one that would happen later in a chronic side effect. Desiree, go ahead and tell me how this patient is positioned, but then tell me how you would position your IMRT lung patient.
Okay, so patient is positioned supine. I see the wing board with a vac lock, and then there's like a blue sponge underneath him. I see the gating on there, so on his chest, arms by his side, and he has a grip ring, and then a knee bolster.
Okay, and if you had the prime candidate of lung, how would you set them up?
I would probably put so I would do the wing board with a vac lock, head frame. I think maybe he has pillows underneath his head or something. Or no, maybe he's on the actual blue. But I would have the arms up. So I would have him on the pegs.
Good.
I wouldn't have him with the grip ring.
Okay.
I would want the arms outside, out of the.
Good.
Mhm.
Why do you think this person didn't have their arms up?
Mobility issues, probably.
Yeah, I mean, we read he's 81. He's got lung tumors. He's also got brain tumors. Um, he's in pretty bad shape. And so all that to say, we're not going to torture this guy. He's IMRT. If he can't bring his arms up, we have to do whatever we can do at the end of the day. The goal is to get him reproducible. If we brought his arms up, we would not. If I spent an hour getting his arms up, I wouldn't get him up every day for treatment. And he's got 33 treatments, so it's something we have to think about. So we had to do what we can do with this situation. So you can treat them down, but it's not optimum. Rebecca, what is the fractionation and dose for this patient?
On the right lung, it's 200 centigrade over 33 fractions for a total of 6,600, and the same for the lymph nodes.
Okay, good. I would expect you guys to be able to pull out the TD55. There's no questions on my exam. I'm 100% sure there's some on Maureen's exam about TD55s and critical structures and tolerance doses. But on my homework assignments, I would expect you to pull out that TD55 and know which ones they are. Okay, let's go with Dariana. Do you think gating was ultimately used for this patient?
Yes.
Yeah, I would say so too. Why?
For it be to make sure there was no changes in the breathing.
Okay. The location of this tumor right here, does that show like, do you think there's probably a lot of movement or probably not a lot of movement?
Yes.
Yeah, it's middle. It really can go either way. Like it's attached here to the rib and to the heart area. But it is in an area that can be affected by the diaphragm. It's not like attached right here. So I would assume that gating was used. I would assume that that area would move a little bit. I would also assume if I can't get somebody to bring their arms up, I'm not going to ask them to hold their breath. So I would assume this person was amplitude gating, and either it was all phases or the doctor then put the phases that they wanted on this specific person. Um, this doesn't seem like an overly compliant patient. So having somebody who is going to fatigue while holding, and it's also a pretty big tumor, having somebody who's going to fatigue while holding their breath and doing that for 33 days is also very difficult. I have a gate on the table right now, and everyone was like, man, he's so good. He just holds that line, but he's a stomach. So we're gating his treatment and he's a stomach. And I'm like, yeah, because he's a stomach. You put a lung on the table with a lung tumor in the middle of it. They already have a hard time breathing. And then you ask them to do these like impossible things, just like our prostates, hold their bladder when they can't even feel their bladder. But it becomes harder in those criteria. So do know that breath holds are more difficult for lung tumors because they have a tumor in their lung. Oh, I answered that one. So this one probably wasn't breath hold. Oh, this is a good one. Clarice, why do you think this was not a candidate for SBRT?
Because it's close to critical structures, it's a higher risk for toxicity.
Yeah, it is close. Sometimes I can SBRT something close to a critical structure. But it is close to multiple. I mean, it goes side to side. For me, the thing is, it's just so darn big. To be a criteria for SBRT, it needs to like hit certain things. I don't IMRT anything this big. Usually, when I'm gonna do an IMRT, it's like 3 centimeters or less. This is definitely larger than 3 centimeters. I couldn't hit all of this with a high dose. I mean, right here, I'm in the carina, I'm in the heart, I'm in the rib, and it's just massive. I can't hit that big of an area. This is probably of this specific lung, at least 1/4 of this lung. I would kill this person if I treated him SBRT. So
Janae,
yeah,
if it was breath hold, it would be listed under technique, right? It would say DIBH there normally.
Yes. It would, so I wrote these. It would be listed in your, so I work in ARIA. When I go to the treatment prescription and I tab down to view all and it expands, it tells me if there's a bolus, if there's a breath hold, if it's gated, if it's amplitude. So in that space, that's where I would look for it. Here I wrote this, and I wrote this a couple years ago. If I had to redo it now and redo this whole class, I probably would have been a little bit more specific and I would have like expanded all the prescriptions. But in the script, absolutely, you can't do anything that's not in the script. So it should be in the prescription of the RX treat. Okay, so we can go into the next one. Let's do Mr. K. All right, we'll start from the top down since Diego's turn anyway. Diego, patient profile.
Mr. K, 86 years old, diagnosis adenocarcinoma of the left upper lobe.
Good. The other one was squamous cell, and this one's adenosis. I'm sure Maureen's talking about this in her class, but lungs, like some of the head and necks, they can be squamous cell and they can be adenone because there's glandular involvement and there's also the cilia lining involvement. So it could go either way. This one is adenone. Clarice, patient background.
Mr. K is an 86-year-old man who recently experienced a persistent cough, shortness of breath, and occasional chest pain. Upon evaluation, imaging tests revealed a long mass located in the left upper lobe of his lung. Further diagnostic procedures, including a biopsy, confirmed the presence of adenocarcinoma.
Okay, Dariana, diagnosis?
Condition, adenocarcinoma of the left upper lobe. Stage to be determined, histology, adenocarcinoma.
Okay. Rebecca, treatment plan?
Given Mr. K's diagnosis of a long mass in the left upper lobe, the treatment plan will involve radiation therapy using stereotactic body radiation therapy, SBRT. SBRT is a precise radiation technique that delivers high dose of radiation to the tumor while minimizing exposure to surrounding healthy tissues. The treatment will be delivered over a shorter time frame compared to conventional radiation therapy.
Okay, Desiree, treatment parameters.
Total radiation dose 5,000 centigrade. Number of fractions is 5. Fractionation scheduled treatments every other day.
Okay. Megan, you will do simulation and imaging.
Mr. K will undergo a simulation session, which will involve a CT scan to precisely map out the tumor and surrounding structures. This helps in treatment planning and ensuring accurate delivery of radiation.
Okay. Abby, treatment planning.
A team of radiation oncologists and medical physicists will use the simulation data to develop customized treatment plan. The goal is to deliver the prescribed dose of 5,000 centigrade to the tumor while minimizing radiation exposure to nearby healthy tissues.
Okay. Patrick, treatment delivery.
Mr. K will receive SBRT treatment over a span of 5 fractions delivered every other day. This treatment schedule allows for higher doses of radiation to be given in fewer sessions. The radiation will be administered using specialized equipment, the True Beam Accelerator, which delivers precise beams of radiation to the tumor. The patient will be treated on inspiration using a deep inspiration breath hold technique.
Sterling, monitoring and supportive care.
Throughout the treatment period, Mr. K will be closely monitored by healthcare teams to assess his response and manage any potential side effects. Supportive care measures such as medications for pain or symptom management may be provided as needed.
Okay. Zena, why don't you tell me the script?
Okay, patient is receiving 5 fractions with a total prescribed dose of 5,000 centigrade. That's GTV1. And that's going to be every other day, 6 X energy, and it's going to be SBRT. And PTV is same number of fractions, but at 3,000 centigrade.
Great. Okay. Danielle, what is an early and late side effect for this patient?
Early side effect might be shortness of breath, and then late might be secondary malignancy.
Okay. Ashley, what would you do differently for SBRT versus an IMRT lung? Would your setup look any different?
Well, at our facility, we had an SBRT board, so it had a lot more indexing. And then they also use compression.
Oh, okay, like a ProLock.
Yeah, like the bar that locked down.
Okay. Did you do that for breath hold also?
For SBRT, yes.
Okay. Okay. It can go either way. I'm glad you mentioned that. So, it basically just locks in a little bit. And then did you have a line RT? How did you gate it?
They had exact track with the surface guidance.
Okay.
Yeah.
Okay. So it just depends on, there's like 1,000 ways to skin a cat. And so there's a billion ways to treat a tumor with SBRT, but you can do a lot or you can do a little. You can use compression and then have somebody take, so basically you're minimizing the amount this person's able to breathe anyway. And then you can have them still taking a breath, which minimizes it even more. It does become very difficult for these patients, but if your patient can do it, then you've just tightened that margin just a little bit. So that is a great way. You can do that with ExactTrack. So that's a great way to do that. This place that I was at does not have exact track. They actually didn't have a 4D CT. I have one now, but so we weren't able to see up front the movement of a tumor. So the doctor would have to just commit to thinking what he was doing from what was happening and where the location of the tumor was. Sydney.
Yeah.
Was gated using what? Why was gating used on this particular patient?
Uh, to because it was why my brain just like to ensure that we accounted for target accuracy and reproducibility to ensure that we didn't hit any organs at risk, like the heart,
Sure.
things like that.
And in specific, if it was here, let's say this was a tumor, it's not, but let's say this is a tumor, and I knew it was going to move a lot. I would gate this to make sure that there wasn't a lot of movement down here. Here, there's less movement, but there still can be some movement, and maybe the doctor wanted to really, really tighten up his margin, specifically because you can see the aorta right here. And so you're concerned that even if there's a little movement, I want to try to lock that in a little bit and get away from the heart, the aorta, as much as possible. So I'm assuming that's why gating was used on this specific one, because the motion to reduce your ITV, the more you reduce margins, the less you're treating healthy tissue. Alan, we just talked about the last one was IMRT and not SBRT because it was close to critical structures. This is still close to critical structures. Why do you think it was SBRT?
I'm honestly not sure.
Because it's small enough where it can be.
Oh, okay. Yeah.
Yeah, it's small enough where it meets the criteria, and after the looking at the DICOM imaging, there was the aorta can be spared enough where you can hit it hard enough, and it's just more convenient to a patient, specifically, somebody who's not doing very good to come in 3, 4, 5 times. 4 isn't an option. I don't know why I said that. 3 or 5 times for radiation versus coming in for 33 times and having that burden on them. So that is why when we can't SBRT something, we want to, for the sake of the patient.
Okay.
Last one. Is this the last one? No, this is the one we just did. Hector, let's start with patient profile.
Patient profile, name Miss L, age 62, diagnosis adenocarcinoma well differentiated of the upper left lobe.
Okay. Diego, actually, we'll go upward. Alan, go ahead and do patient background.
Mrs. L is a 62-year-old female who recently experienced symptoms such as chronic cough, chest pain, and weight loss. After undergoing diagnostic tests, including imaging scans and a biopsy, diagnosed with adenocarcinoma in the upper left lobe of his lung.
Okay, thanks. I originally tried to take away all describing factors of these patients, but then I realized once I added the photos, you guys would know if it was a man or a female. So then I tried to go back, and so some of these are all over the place, and I'm sorry about that. Sydney, go with treatment plan.
Given Mrs. L's diagnosis of endocarcinoma in the upper left lobe, the treatment plan will involve radiation therapy using the stereotactic body radiation therapy (SBRT) technique. SBRT delivers precise high-dose radiation to the tumor while sparing nearby healthy tissues. The treatment will consist of 5 fractions, each delivering a dose of 10 gray. resulting in a total dose of 50 centigrade.
Okay. Ashley, treatment parameters?
Total radiation dose 5,000 centigrade. Number of fractions 5. Fractionation schedule. Treatments every other day.
Okay. We'll skip simulation. Treatment delivery, Danielle.
Mrs. L will receive SBRT treatment over a span of 5 fractions delivered every other day. This treatment schedule allows for higher doses of radiation to be given in fewer sessions. The radiation will be administered using specialized equipment, a true beam linac, which delivers precise beams of radiation to the tumor. The patient will be treated using abdominal compression and an amplitude gating technique.
Okay, Zena, monitoring and support. No, we don't need to do that. Zena, do me the script.
Okay,
Oh,
patient is head and neck.
Is it not?
I'm sorry, no, it's not. I was
Yeah.
like, what? Okay, patient is lung. We are treating 5 fractions at a total prescribed dose of 5,000 centigrade every other day, 6 X or photon, and it's SBRT.
Okay. Sterling, what kind of treatment was prescribed for Miss L?
SBRT, 5 treatments.
Good. And then what body part would you say this was?
Also upper lung.
Good. Okay. As far as the positioning, this right here is what I think it was Sydney, or was it Ashley? When you guys just mentioned that you use the Prolock board, this is a Prolock board. It's like an overlay with more indexing on it. You can have a wing board that attaches to it, and then you could have devices for compression. This one is the plate. There's also it just basically sits on the diaphragm. There's also a bladder, which is like a cuff, like where you get your blood pressure. It does the same thing to your diaphragm. It just puts pressure on there. It restricts the motion of the diaphragm at the end of the day. That's the goal of it. The reason that it's SBRT is because it's small. This one is like a great spot for an SBRT. It's away from critical structures. It's nice and small. It's going to lock in very nicely. Breath hold wouldn't do a great job for this. Compression's almost better. It'll just lock it in, and then it's easier to then not have the patient have control over it. We have more control. This isn't going to move very much. It's pretty close to the rib. It's the upper lobe. So all these things are in line with the lecture that we just talked about and what we would expect to see on a lung. That is it for class today. Again, I thank you guys all for switching your times. If anybody has any questions, I'm here after class. If not, you guys have a good rest of your day. This is getting recorded. I'm going to try to put it in Moodle, but if not, I'm absolutely going to email some people. I don't know the answer if I could record all the other classes, but at least I'm recording this one because this one was on me. Zena, did you have a question?
I did have a question, and it was more so from what I've seen on the clinic, and I wanted to get your perspective. When you're treating a patient for lung, do you have issue with like surface guidance with patients that are like barrel chested?
Ooh, I have problems with both surface guided and with RGSC with patients that are barrel chested. And with the RGSC, the frogs specifically, the people who have that diaphragm that then concaves into their stomach, that also becomes a problem. But that being said, is your gating through the gating through the skin rendering, or is it through your imaging?
So when we did simulation, we used RGSC, but in the treatment, we're using Align RT, and it would like totally throw off, and it was like every day. So I wasn't sure if there's like a different, like a preferred way of treating patients that are barrel chested that you've seen.
Yeah, and is your beam hold through your Align?
It was through Align.
Yeah. It's not my favorite. I think Align is a really good product for breasts. I don't think Align is the end all for lung because it's inside. So what I prefer on a lung tumor is actually imaging. On my first day, I prefer to image on a SBRT in between each arc and make sure that it's not going to move. And then I feel good about because I'm just skin rendering and so much is happening inside the body. That my preference is not to use skin rendering on a lung, specifically an obese patient or a barrel chested patient, because too much happens here and my tumor's inside here. If I feel like there's a separation of like 2 or 3 centimeters from what I'm tracking to where the tumor is, I don't love it. We are a little bit, I'm at USC and we're a little bit image heavy intrafraction, but I like it. I feel like all my career has been imaging, and I feel like imaging, I'm looking at the tumor versus looking at the skin. So in that case, I would loosen up if you can, have physics loosen up the parameters of vision, and then do a little bit more imaging work to show that yes, this is stable per my imaging, because clearly my Align isn't as stable as my imaging can be.
Okay.
Any other questions? All right. Well, you guys have a good rest of your day. I will be available by email for this weekend if you guys need anything. And good luck on your site specifics. I can't wait to see them. They're going to be great. I already know it. Okay.
Have a good weekend.
Thank you. Bye.
You.